Hello, everyone, and a very warm welcome to all of you. Today, we are going to start a very interesting topic, something absolutely fascinating in medicine, the endocrine system. Now, what is it, you ask? Just imagine it's like a secret government, a sophisticated communication network that is running your entire body, making sure everything is in perfect balance. So let's get started, shall we?
Okay, so let's begin with a small question for you all. Think about this. Deep inside your head, right at the base of your brain, there's a tiny gland, no bigger than a bean. But don't go by its size. This little thing is the master controller, you can say the CEO, of your body's entire hormonal orchestra. Any guesses? Yes, of course, I'm talking about the pituitary gland. And believe me, it is the hero of our story today.
So what exactly is this system that the pituitary is the boss of? Well, the endocrine system is basically the body's internal WhatsApp group, It's a command center made up of different glands, and these glands produce special chemical messengers, which we call hormones. Now, these hormones, they travel all through your blood, and they give orders to different organs, making sure everything, and I mean everything, is in a state of perfect balance. This is the key term, remember it, metabolic equilibrium. Right, so if the pituitary gland is the prime minister's office, then who are the people working there? Who are the officers? Let's meet the key players inside the anterior pituitary. You can just think of them as the cabinet ministers in our body's government. And have a look at this. This is what's really interesting, how a healthy pituitary looks under the microscope. It's beautiful, no? A very colorful mix of cells. You see the pinkish ones? Those are the acidophils, and the more purple-looking ones are the basophils. Each color represents a different type of cell, a different minister, each producing a very specific hormone. It's a perfect picture of everyone working together. Total teamwork.
Okay, now this is the cabinet list. This slide is very important, so I want your full attention. First up, we have somatrophs. Their job is growth. Simple. Then, lactotrophs. They manage milk production. Next, corticotrophs. These guys handle stress by giving orders to the adrenal glands. Then we have thyrotrophs, which control our metabolism by managing the thyroid. And last but not least, the gonadotrophs, which are looking after our reproductive functions. See, each minister has a very clear-cut job.
But wait a minute, who is telling these ministers what to do? All right, in any government, the orders must come from the top, right? So, in our body's system, the president is the hypothalamus. It's sitting just above the pituitary, and it's sending all the signals, telling the ministers when to release their hormones and when to stop. A perfect chain of command from top to bottom. Okay, so far, so good. The system is elegant, it's efficient, it's balanced, everything is perfect. But in medicine, we always have to ask the what-if question. What happens when things go wrong? What if one of these ministers goes rogue, stops listening to orders? And that question brings us to this condition, hyperpituitarism, basically a state of hormone excess, too much hormone. And what is the most common reason for all this chaos? A tumor, specifically something we call a pituitary neuroendocrine tumor, or PITNET for short. Now, this happens when a group of cells of just one type, let's say only the somatotrophs, start multiplying like crazy, uncontrollably. They form a rogue group that just will not stop pumping out its hormone. And this picture illustrates the problem perfectly. Just look at the two images. On the left, you see that healthy, colorful, diverse mix of cells in a normal pituitary. Now, look to the right. That is a PITNET. Can you see how it's just one type of cell again and again and again? It's just a monotonous sheet of rogue cells. The beautiful diversity is totally gone, and it's replaced by this chaotic uniformity. But the problem is not just about the excess hormones. These tumors, they grow, and as they get bigger, they cause what we call a mass effect. Have a look at this slide. This huge tumor is physically pushing against the brain, and very importantly, the optic nerves. This pressure can cause very serious vision problems, like losing your side vision. This is a classic clinical sign. We call it bitemporal hemianopsia. Very important to remember. Let's take one specific example of a rogue agent, a somatotroph PITNET. This one overproduces growth hormone. Now, the effect is dramatically different depending on the age of the patient. If this happens in a child, before their bone growth plates have closed, the result is gigantism. The child becomes extremely tall. But if the same thing happens in an adult, their long bones can't grow longer. So what happens? They grow thicker. And this condition is called acromegaly, which leads to enlarged hands, feet, and very distinct facial changes. Okay, so we've seen the chaos that happens when there is too much hormone production. But now, what about the exact opposite? What happens if the entire command center just shuts down completely? This condition is called hypopituitarism, basically a failure to produce enough hormones. And what is truly remarkable here is that our pituitary gland is incredibly tough, very resilient. You actually have to lose about 75% of the gland before you start seeing a critical body-wide failure. But once that line is crossed, oh, the consequences can be absolutely devastating. So what could cause such a massive failure? Well, it's usually something catastrophic. It could be a large, destructive tumor that just crushes all the healthy tissue, or a severe traumatic brain injury, a sudden bleed into the gland, which has a specific name, pituitary apoplexy, or, and this is a classic condition you must remember for your exams, Sheehan's syndrome. This happens when severe blood loss during childbirth causes the pituitary, which is already enlarged, to die from a lack of oxygen. All right, now let's shift our focus a little bit. We've been talking about the central command, the pituitary. Let's move to one of its key field departments, the thyroid gland. Because you have to understand, problems don't just happen at the top of the chain, they can also happen further down the line.
The thyroid gland. It's located right here in the front of your neck. It is the body's chief metabolism regulator. What does that mean? It controls the body's entire energy budget, how fast you burn fuel, your body temperature, and even your heart rate. So you can see it's a very, very important department.
So what if this department goes into overdrive? Well, that condition is called hyperthyroidism or thyrotoxicosis. The body just gets flooded with thyroid hormones. It's like the body's engine is stuck in the highest gear and it's just running at maximum speed all the time. And so the clinical signs are exactly what you would expect from a system that's in overdrive. The basal metabolic rate just shoots up. The patient feels hot all the time, they sweat a lot, their skin is warm and flushed. And they are losing weight, even though they're eating more. Their appetite has increased. And of course, their heart is just racing. We call that tachycardia. And they can feel it beating, which is palpitations. The entire body is just running too fast and too hot. So, from the master gland in the brain all the way down to the metabolic engine in the neck, we are seeing a common theme, aren't we? The health of our entire body, it all depends on a very, very delicate balance. And this quote here, it summarizes it all perfectly. The endocrine system is a highly integrated group of organs that orchestrate a state of metabolic equilibrium. Orchestrate. That's the key word. It's like a symphony orchestra where every hormone, every gland has to play its part perfectly. If even one instrument is too loud or too quiet, the beautiful music of our health is just completely ruined. So, I will leave you all with one final thought to ponder. If a tiny gland, no bigger than a single bean, has so much power over our growth, our energy, our mood, our entire lives, what does that tell us about the incredible fragility and complexity of these hidden systems that are governing our well-being? It is something truly amazing to think about, isn't it? Thank you. Hello, everyone, and welcome back. Today, we're going to talk about a very, very important gland. It's tiny, but trust me, its impact is massive. We are talking about the thyroid, your body's master regulator. Think of it as the engine, the thermostat, everything, all rolled into one. So let's jump right in, shall we? Okay, first things first, I want you to look very closely at this patient's eyes. This wide, staring gaze, this isn't just an expression you see. In our field, this is a huge clue. The eyes are truly a window into what's happening deep inside the body. They're telling us a story about a system that's been kicked into overdrive. And this brings us to the big question. What is this patient's body trying to tell us with signs like these? For the next few minutes, I want you to think of yourselves as clinical detectives. We're going to follow the clues, one by one, to really understand the pathology of the thyroid gland. Now, the first thing you need to grasp about the thyroid is that its problems usually show up in one of two opposite ways. It really is a gland of extremes. Either the body's engine is racing like crazy, burning through fuel, or it's running so slow it's about to stall. And here you can see those two extremes side by side. On the one hand, you have hyperthyroidism. Everything is revved up. Metabolism is high, so there's weight loss. Patients are anxious, hyperactive, they can't stand the heat, and their heart is just racing away. On the other hand, you have the complete opposite, hypothyroidism. The whole system just slows down. Weight gain, sluggishness, always feeling cold, a slow heart rate, even the gut slows down, leading to constipation. See? Two sides of the same coin, but clinically, they're worlds apart. All right, so let's dig into the first extreme, hyperthyroidism. This is what happens when that engine is just stuck on full throttle, flooding the body with hormones and pushing every single system to its absolute limit. So what's usually behind this? Well, the most common culprit is a fascinating condition called Graves' disease. It's an autoimmune problem, but it has a very clever twist. Instead of destroying the gland, the body produces these antibodies that perfectly mimic TSH, the hormone that normally tells the thyroid to get to work. So the body is basically tricking itself, constantly shouting at the thyroid, "Go, go, go, make more!" And this is what it actually looks like. Grossly, on your left, you can see the gland is huge. It's all beefy and red. That's from all the extra blood flow. And then when you look under the microscope, look at that on the right. The cells are tall, they're crowded, they're hyperactive, and you see how they're sort of nibbling away at that pink stuff in the middle, the colloid? That scalloped appearance is a dead giveaway for a gland that is working way, way too hard. The structure is telling you the story of its function.
Okay, so we've seen the engine in overdrive. Now let's flip the coin and see what happens when the engine just stalls. We're talking about hypothyroidism, where the whole body just seems to run out of steam.
Now, for us here in India, where iodine deficiency isn't the big issue it used to be, the number one cause of hypothyroidism is another autoimmune disease, Hashimoto's thyroiditis. But this time, the immune system isn't playing tricks. No, this time it's a destroyer. It sees the thyroid cells as an enemy and launches an all-out attack to eliminate them. Now, this is a number I really want you to remember. 10 to 1. That's the approximate female to male ratio for Hashimoto's. For every one man who gets it, about 10 women are affected. This is so important clinically. When a female patient comes to your clinic complaining of fatigue, weight gain, or feeling low, Hashimoto's must be at the top of your mind. And if you look at this slide, this is not a gland at peace. This is a war zone. All those tiny, dark purple dots you see, those are lymphocytes. An army of them has invaded the thyroid tissue and is systematically wiping out the normal follicles. It's literally a civil war happening right inside the gland itself. Okay, so Hashimoto's is the big one, for sure, but it's not the only way the gland can get inflamed. There are other forms of thyroiditis, and they present very differently, so it's important that you know how to tell them apart. Right, so let's quickly compare. You have Hashimoto's, which we've seen is a chronic, slow destruction. Then there's subacute thyroiditis, also called de Quervain's. The key feature here is that it's often very painful, and we think it's triggered by a virus. And finally, there's painless thyroiditis, which can pop up after a woman gives birth. The important thing to remember is that both subacute and painless thyroiditis usually get better on their own. They are transient conditions. So far, we've been talking about function, right? Too much hormone or too little hormone. Now let's switch gears and talk about structure. Specifically, what happens when the thyroid gland itself enlarges, forming what we call a goiter, or when it develops nodules. And you can see exactly what I mean right here. On the left is the clinical picture, a large, very obvious swelling in the neck. That's a goiter. And on the right, that's what we see when we look inside. The gland isn't just big, it's completely distorted by all these different sized nodules. This is a classic multinodular goiter. So a patient comes to you with a thyroid nodule. The million-rupee question is always, is this benign or is it malignant? We have a set of clues we use to figure this out. For example, a solitary nodule in a younger male is a bit more concerning than multiple nodules in an older female. A history of radiation to the head or neck, that is a huge red flag. And we also look at function. A hot nodule that's actively taking up iodine is usually benign. It's the cold nodules, the ones that are just sitting there not doing anything, that make us more suspicious. We put all these clues together to solve the case. And this brings us to our last topic for today. And it's a real puzzle, a major puzzle in modern medicine. The curious case of thyroid cancer. What's the puzzle, you ask? Well, the fact is, the number of people getting diagnosed with thyroid cancer has been shooting up. For decades now, the rate has been rising dramatically, year after year. But in here is the strange part. Even though these diagnoses are going through the roof, the number of people actually dying from thyroid cancer has stayed incredibly low. The 5-year survival rate is more than 98%. That's because most of these are small, slow-growing cancers that we find very early, and our treatments are extremely effective. The prognosis is, thankfully, excellent. So this is the question I want to leave you all with. Why are we finding so much more of it? Is there a true epidemic of thyroid cancer happening? Or, with our fancy ultrasounds and advanced imaging, are we just getting better at finding these tiny little tumors that, in the past, would have just sat there harmlessly for a person's entire life? This debate between a real increase and a phenomenon of overdiagnosis is one of the biggest conversations in medicine today. There are no easy answers. Something for you all to think about.
All right, everyone. Good morning. Good morning. Welcome back. Today, we're jumping into some really fascinating cases in endocrine pathology. So I want you to put on your detective hats because today we are not just learning, we are going to be solving some medical mysteries together.
Just think about it for a second. One tiny little gland that decides to go haywire, it can throw the entire body into complete chaos. We're talking everything from your bones to your brain. That's the power and, of course, the danger of the endocrine system.
So, are we all ready to begin? I hope you've had your chai. Chalo, let's start with our very first case in endocrine pathology.
Okay, first up for us, the thyroid nodule mystery. So patient walks into your clinic, lump in the neck. Our job, we have to figure out what it is. And the two main culprits we're going to be looking at are papillary and follicular carcinoma.
Okay, let's get into it. Here on the slide, what you are seeing is a gross specimen, a single, solitary nodule. And this is a very, very common way patients present. And this is exactly where our investigation begins. What could it be?
So like I said, we have two main suspects on our list. On your left, we have papillary carcinoma, and on the right, follicular carcinoma. Now listen, these are the most common types of thyroid cancer, but they behave in completely different ways. Our job is to find the clues that tell them apart.
Let's open the case file for suspect number 1, papillary carcinoma. Now this one is the big one, beta, the most common type you will see. Notice how it spreads. It likes to travel through the lymphatics. But here's the good news. The prognosis is excellent, really, really good. We're talking over 95% 10-year survival. But the most crucial point, the defining clue, is hidden deep inside the cell's nucleus.
And here it is. This is the money shot, as they say. Look closely at this slide, everyone. Do you see those nuclei? They look empty, pale. We have a name for this, orphan Annie eye nuclei. It is a classic, beautiful finding. When you see this under the microscope, you can be very, very confident in your diagnosis. This is the telltale sign.
All right, now let's move to our second suspect, follicular carcinoma. Totally different story here. You see, it's linked to iodine deficiency. And it doesn't bother with the lymphatics. No, this one prefers to travel by blood, what we call hematogenous spread. The prognosis here, it's a bit trickier. It all comes down to invasion. And that brings us to the key. For follicular, it is all about the capsule. Now look at this. This right here is the smoking gun for follicular carcinoma. You can see those tumor cells literally breaking through that fibrous capsule. This is invasion. And this is why, and listen carefully, this is very important for your practicals, this is why a fine needle aspiration, an FNA, cannot diagnose follicular carcinoma. You can only suggest it. To be sure, you need to see this invasion, and for that, you need the whole specimen out.
So, let's just summarize everything. This table shows you the final verdict perfectly. For papillary, what's the key clue? It's the orphan Annie nucleus. For follicular, it's all about that capsular invasion. Papillary spreads through lymph. Follicular spreads through blood, and that's why you can diagnose papillary on a simple needle biopsy, but not follicular. And of course, all of this affects the prognosis. Simple, isn't it?
Okay, case 1 solved. Good job. Now on to our next challenge. Let's move from the thyroid to calcium chaos, the parathyroid investigation. Here, the whole body's balance is on the line.
Okay, imagine this. You're in the clinic. A routine blood test comes back and the patient's calcium is high. Very high. As a doctor, what's the first thing that should pop into your head? What are the possibilities? This is a classic clinical problem, and I'll tell you, the parathyroid gland should be your prime suspect.
And this slide shows you exactly why. Just look at this chart. In primary hyperparathyroidism, the cause is overwhelmingly a benign tumor, a single adenoma in 85 to 95% of cases. Just think about that. It is almost always just one rogue gland causing all the trouble. Hyperplasia is a distant second. And as you can see, carcinoma is incredibly rare.
So how does this high calcium actually show up in a patient? For this, you must remember this for your exams. This is the classic mnemonic,
painful bones, renal stones, abdominal groans, and psychic moans. It perfectly captures the widespread effects of having too much calcium floating around in the blood.
So let's take a closer look at painful bones. This is not just some vague ache. This slide shows you what is actually happening at the microscopic level. You see those cells, the osteoclasts? They're literally tunneling through the bone, creating these patterns that look like railroad tracks. We call this dissecting osteitis. It's the high parathyroid hormone that's driving all this destruction.
So we've talked about the common thyroid cancers, but we must also look at the extremes, right? The more aggressive types. So let's take a look at a completely different kind of beast, medullary carcinoma.
So the crucial point here is that this cancer does not come from the follicular cells that make thyroid hormone. No. Medullary carcinoma comes from the parafollicular C cells. Now, these are neuroendocrine cells, and their main job is to make the hormone calcitonin. This different origin is the key to understanding everything about this tumor.
And this slide shows you the consequence of that. Because the tumor is made of C cells, it's punking out massive amounts of calcitonin. So much, in fact, that the calcitonin protein itself starts to deposit in the tissue as this pink, glassy material that you see on the slide. This is amyloid. Seeing this amyloid is a huge, huge clue for medullary carcinoma.
Okay, we have covered a lot of ground today, I know. So let's distill it all down. These are the professor's final pearls. These are the high-yield facts that you must take away from today for your exams and for your future clinical practice. Pearl number 1. For papillary carcinoma, your entire focus has to be on the nucleus. Just remember orphan annii. That's your diagnostic anchor. Simple. Pearl number 2. For follicular carcinoma, you can forget the cells for a minute and look at the border. Is it invading the capsule? That is the only question that matters for the diagnosis. Pearl number 3. Medullary carcinoma is the odd one out. So always remember this chain of logic. It comes from C cells, which produce calcitonin, which then deposits as amyloid. C cell, calcitonin, amyloid. Got it? And our final pearl, number 4. When you see a patient with primary hyperparathyroidism and high calcium, what's the most likely cause? By far, it is usually a single rogue adenoma, just one small tumor causing such big problems. So there you have it. You have the clues, you have the patterns, you've seen the microscopic signs. You are now equipped with the basic tools of an endocrine pathologist. So the real question is, how are you going to use them to solve your next case? That is all for today. Thank you, everyone.
Hello, everyone, and welcome. Today, we're going to tackle a very, very important topic, one that affects millions of people around the world, diabetes mellitus. We'll start with the fundamentals, how our bodies are supposed to handle sugar, and then we'll dive into what happens when this delicate, finely tuned system goes wrong.
All right, so here's our plan for this session. First, we'll look at the normal function. Then we'll see what happens when it breaks. We'll compare the two big types of diabetes, and then look at both the immediate emergencies and the slow, long-term damage. By the end, you'll have a really complete picture. Okay, first things first, we absolutely have to get to know the star player in this whole story, insulin. You can think of it as the manager of the body's entire energy economy. Everything else we talk about today really builds on what this one hormone does.
So what is insulin really? Well, simply put, it's the master builder hormone of your body. Its job is anabolic, which is just a technical way of saying its whole purpose is to build things up and store energy for later. It's all about saving for a rainy day.
Now this is where things get really elegant. The body has this incredibly smart system to make sure insulin is only released when it's actually needed. It works like a beautiful chain reaction. Glucose comes in, the cell makes energy, or ATP. That energy flips a switch on the cell membrane, which then opens a gate for calcium to rush in. And that rush of calcium, that's the final signal that tells the cell, okay, release the insulin now. It's just a perfect system.
And you can see its job description right here. In your muscles, fat, and liver, insulin's message is always the same. Store, store, store. It tells them to take up glucose from the blood and pack it away for later. It even tells the liver, hey, stop making new sugar for a bit. Let's focus on storing what we've already got.
So that's the ideal situation, how it's all supposed to work. But what happens when this perfectly balanced system breaks down? Well, that's when we enter the world of diabetes mellitus. And this brings us right to the heart of the problem. What happens when you either don't have enough insulin or the insulin you do have just isn't working properly? This is the core question, and the answer really boils down to two main types of failure.
Remember these two ideas. They are absolutely key. You can think of it like a key and a lock. Insulin deficiency is like not having enough keys. Insulin resistance, that's like having the key, but the lock is rusty, it won't turn. Either way, the door doesn't open, and the message doesn't get through.
Now, these two basic failures lead to two very different diseases with two completely different stories, type 1 and type 2 diabetes. And it is so important to understand that they are not the same thing at all. This table does a fantastic job of laying out the differences. Just look at the typical age of onset or the body weight. But the really critical difference is in the cause. In type 1, it's an autoimmune attack. The body's own immune system destroys the insulin-producing beta cells. In type 2, the story starts with insulin resistance, and over time, those beta cells just get exhausted from trying to keep up.
And you don't have to take my word for it. The proof is right here, under the microscope. On the left, in type 1, you can literally see the immune cells invading the pancreas. It's a war zone. But on the right, in type 2, you see something totally different. This buildup of a gunk-like protein called amyloid. Two completely different pathologies telling two very different tales.
Another key point, especially for type 1, is that it doesn't just happen overnight. It's a slow, progressive attack that can go on for years, completely silently. You can see here a person goes through stages where the autoimmune process is happening, but they have no symptoms. By the time they actually feel sick, a huge amount of damage has already been done. For type 2, the story is a bit different. It begins with that rusty lock, insulin resistance. The cells just aren't listening. So what does the pancreas do? It shouts louder. It pumps out more and more insulin to try and get the message through. But you can only shout for so long. Eventually, the beta cells get tired, they get exhausted, and they just can't keep up anymore. That's when blood sugar starts to rise. Okay, let's now shift gears and talk about the immediate dangers. What happens when blood sugar levels go way out of control and become a medical emergency? The classic symptoms that bring many people to the doctor are a direct result of the body trying, and failing, to cope with high blood sugar. So there's so much sugar in the blood that it spills into the urine, and water follows it. This makes you urinate constantly and become incredibly dehydrated, which in turn makes you intensely thirsty. But at the same time, your cells are literally starving for that glucose they can't access, which makes you ravenously hungry. It's a terrible, vicious cycle. Now, this can escalate into two very dangerous states. In type 1, you often see something called DKA. With no insulin, the body panics and starts burning fat like crazy, which produces acidic molecules called ketones. The blood literally becomes acidic. In type 2, you're more likely to see HHS, where the blood sugar gets sky high, causing extreme, life-threatening dehydration. So think of DKA as a crisis of acid and HHS as a crisis of water loss.
And we have to mention the other side of the coin, too. Sometimes the treatment for diabetes can cause an emergency. Hypoglycemia, or dangerously low blood sugar, can happen if someone takes too much insulin. And this is just as serious. It needs to be treated immediately.
All right, so we've covered the acute crises, but now we need to talk about the long game, the slow, silent, and relentless damage that high blood sugar can cause over many, many years. This is really the mean battle in managing diabetes long term. And this is the question that every patient and doctor has to confront. What's the price you pay for years of high blood sugar? The unfortunate answer is that it wages a slow-motion war on your blood vessels, the very lifelines that supply every part of your body. This image here is just incredible. We're looking at a microscopic filter in the kidney. And do you see that thick gray band? That's the basement membrane. In diabetes, it gets really thick, but paradoxically, it also gets leaky. It's like a pipe that's getting thicker on the outside, but is full of tiny holes. This is a fundamental problem that we call microangiopathy, or small vessel disease. And this damage doesn't happen by chance. It's driven by specific biochemical pathways that go into overdrive when there's too much glucose around. You can think of it as a four-pronged attack. You've got these harmful AGEs forming, you've got activation of PKC, and you've got these other two pathways causing all sorts of chemical chaos and stress inside the cells. And here you can see the heartbreaking end result in an organ like the kidney. On the left is the whole kidney. It's shrunken, it's scarred, and on the right, you can see why. Under the microscope, you see those dense pink nodules. That's irreversible scarring that has completely destroyed the normal kidney tissue. It's a direct line from microscopic damage to organ failure. So, to wrap it all up, what is the main takeaway?
Please remember, diabetes is not just one thing. It's a complex group of disorders. Whether the problem is a lack of insulin, as in type 1, or resistance to it, as in type 2, the result is a cascade of problems, from immediate crises to devastating long-term damage, especially to our blood vessels. Understanding which story is unfolding is the first step.
And that leaves us with one final, very important thought to consider. We know for a fact that the damage begins long before a person ever feels sick. So the real question for the future is, how can we use that knowledge? How do we move beyond just treating this disease and shift our focus to catching it earlier, or even better, preventing it from ever taking hold in the first place? That is the challenge ahead of us. Thank you.
Hello, everyone, and welcome back to our class. We're continuing with Chapter 24, and today we're on Part 5. We're going to talk about the body's internal messaging system, the endocrine glands. Now, I want you to think of it like this. It's like the body has its own private WhatsApp, but instead of sending you good morning forwards, it's sending out these powerful chemicals called hormones. So just think about this for a second. What happens when these very important messages get all mixed up, huh? What if one gland is shouting too much, or another one just goes completely silent? Well, that chaos, my friends, is what we call hormonal imbalance. And to understand this, we're going to look at two superstar glands, the pancreas and the adrenals. Charlo, let's get started. You know, the entire field of endocrinology, all those big, fat textbooks you have to read, it can all be boiled down to one very simple idea: balance. It is an extremely delicate tightrope walk. The body needs just the right amount of every hormone to work properly. Not too much, and definitely not too little. In this slide, it shows you the main principle perfectly. Almost every single endocrine disease you will ever see in the wards can be understood with this simple idea. Is the gland working overtime, making too much hormone? We call that hyperfunction. Or is it being lazy, producing too little? That's hypofunction. It's really as simple as that. Let's see how this works in real life.
Okay, first up, the pancreas. We all know where it is, just sitting quietly behind the stomach. But don't let that fool you. Its job is massive. It is the master controller of our blood sugar, and it does this mainly through the hormone insulin. So, let's see what happens when this control system messes up.
So, on the too little side of things, the hypofunction side, we have a condition all of you know: diabetes mellitus. What's happening here is that there's not enough insulin action. Think of insulin as the key that opens the cell door for sugar to enter. If the key doesn't work, the sugar, or glucose, gets stuck outside in the blood. This leads to high blood sugar, which we call hyperglycemia. Now, why is this so bad? Well, over many years, that extra sugar in the blood acts like a slow poison. It damages the big blood vessels, which can lead to heart attacks and strokes. It completely destroys the kidneys, that's what we call nephropathy. It damages the eyes, sometimes causing blindness. It attacks the nerves, and on top of all that, it weakens your immune system, making it harder to fight off even simple infections. The real danger of diabetes isn't the high sugar today, it's these long-term problems.
And this is not some rare thing, you know. Just look at this number. For patients who have had diabetes for more than 15 years, a full 80%, 80, will develop nerve damage. That is a huge, huge number. It really shows you just how destructive this too little insulin action can be over time.
Okay, so that's the too little story for the pancreas. But remember what I said, it's a balancing act. So what happens if the pancreas goes crazy in the other direction and starts producing too much insulin?
Well, that leads us to a hyperfunction condition called an insulinoma. Basically, it's a type of tumor in the pancreas, a pan-nen, that just pumps out massive amounts of insulin. All that extra insulin shoves sugar out of the blood so fast that the blood sugar level drops dangerously low. This is called hypoglycemia, and let me tell you, it's just as dangerous as high blood sugar because your brain absolutely needs glucose to function moment to moment.
And here, have a look at what it looks like under the microscope. You see these cells? They all look very similar, very uniform. We call that monotonous. Now look closely. You see that pink stuff scattered around? That is amyloid deposition. It's a classic feature that helps us pathologists say, aha, this is an insulinoma. It looks quite beautiful, actually, but it's a very dangerous thing to have. All right, so we've seen the balance of insulin. Now, let's move on to our next example. We're going up a little bit, from the pancreas to these two small glands that sit like little caps on top of your kidneys, the adrenals. These are your stress management centers. They produce really important steroid hormones, like cortisol. So first, let's look at the too much scenario, the hyperfunction. When the body has way too much cortisol for a long time, we get a condition called Cushing's syndrome. This is the absolute textbook example of an overactive adrenal gland.
And the physical signs? Well, they are very obvious. The extra cortisol moves fat around, causing obesity in the trunk area. It creates this very classic round face, which we call a moon face, and it makes the skin thin and easy to damage, causing these big stretch marks or striae on the abdomen. When you see a patient who looks like this in the clinic, the first thing that should pop into your head is Cushing.
So where is all this cortisol coming from? Take a look at this slide. On the top, that's a normal, thin adrenal gland. Now compare that to the one on the bottom from the Cushing's patient. You see how thick and yellow and big it is. That's what we call hyperplastic. This enlarged, overactive gland is the factory that's pumping out all that extra hormone. So it's very clear that too much cortisol is a big problem. But we always have to think about the other side of the balance, right? What happens when the adrenal glands start to fail? What's the story of too little cortisol?
This brings us to Addison disease. It's not very common, but it's a very serious condition where the adrenal cortex slowly gets destroyed, usually because the body's own immune system attacks it. This is our classic example of adrenal hypofunction. Without a working adrenal cortex, the body is basically starved of cortisol and other essential steroids. It's running on empty.
And you know, the original description from Thomas Addison himself way back in 1855 is still the best. He talked about general languor and debility, basically a deep, profound weakness and tiredness, remarkable feebleness of the heart's action, and this peculiar change in the color of the skin, a sort of hyperpigmentation. It really is the picture of a body that is slowly shutting down.
So let's just put them side by side. Look at this table. It's a perfect story of opposites, isn't it? Cushing's is too much cortisol, Addison's is too little. Cushing's gives you central weight gain, Addison's gives you extreme weakness. Cushing's can give you high blood sugar and high blood pressure, Addison's gives you low blood pressure. It's the perfect illustration of our main theme today. Balance is everything.
So why do we spend all this time comparing these things? Because understanding this one concept, this idea of balance, is absolutely fundamental. This is the key that is going to unlock your understanding of a huge, huge part of medicine.
At the end of the day, this is the one thing I want you to take home. Endocrinology is the story of balance. Everything from your mood to your metabolism to how you handle stress, it's all controlled by these hormones. A tiny bit too much or a tiny bit too little, and the whole system can be thrown into complete chaos. So maintaining this delicate balance is, quite literally, life itself.
And that leaves us with one final thought. We've only just looked at 2 glands today. When you see this incredible complexity, this constant delicate balancing act that is happening inside all of us every single second, it makes you wonder, doesn't it? What does it truly mean to be healthy? It's something to think about. All right, that's all for today. Thank you, everyone.
Chalo, bacho, let's get started. Today, we're going to talk about a tiny gland that packs a massive punch, the adrenal gland. We are going to look at both extremes, what happens when it completely fails, and what happens when it goes into total overdrive. I am telling you, this is one topic you really want to understand properly, not just for your exams, but for your entire clinical career.
And we are starting with something really dramatic. Just look at this picture. This is Waterhouse-Friderichsen syndrome. The gland is basically gone. It's drowned in a sea of its own blood, a massive hemorrhage. This is what complete, catastrophic failure looks like. It's a very powerful reminder of just how critical this little gland is.
So, here's our plan for today. First, we'll cover what happens when the gland fails. That's adrenal insufficiency. Then, we will flip the coin and see what happens when it overgrows and forms tumors. Then we get to the real drama in the medulla with pheochromocytoma. And finally, we will connect everything together with the genetics, the MEN syndromes. So, let's begin.
Okay, first step. Let's imagine the adrenal cortex is like a busy factory, okay? Pumping out hormones. Now, what happens when this factory suddenly shuts down? That is exactly what we call adrenal insufficiency. The hormone production just drops, and the whole body starts to suffer.
Now, this is very interesting. In developed countries, what do you think is the #1 reason for this failure? Look at this chart. A huge 80 to 90% of the time, it's the body attacking itself. Autoimmune adrenalitis. Now, for us, here in India, we must always keep infections like tuberculosis high on our list. But you need to know about this autoimmune cause. It's a big one.
So why is the body attacking itself? Well, it's not just random.
It's often part of a bigger problem, a syndrome called APS1. And it all comes down to a defect in one single gene, the AIRE gene. Think of AIR as the security guard of the thymus. Its job is to find and destroy any rogue T cells that want to attack our own body. But if the AIR gene is faulty, the security guard is sleeping, and these rogue cells escape and go on a rampage, attacking organs like the adrenal gland.
And here is the evidence of that attack. The view under the microscope. The normal, beautiful architecture of the cortex is just gone. It has been completely invaded by all these lymphocytes. You can hardly even find any of the original cortical cells left. The factory hasn't just been shut down, it has been destroyed. Okay, now everyone pay attention. This table is pure gold. It's absolutely critical for your exams, for your viva, for your clinical life. You have to, know the difference between primary and secondary insufficiency. Is the problem in the adrenal gland itself, or is the pituitary gland not doing its job? The two biggest clues: skin hyperpigmentation and high potassium, or hyperkalemia. If you see those two, you should immediately think of primary failure. Please remember this. All right, let's switch gears completely. We have seen what happens when the gland fails. Now, let's look at the exact opposite problem. What happens when it starts to grow uncontrollably and form tumors? We'll start with the cortex. Just look at the difference here. It's like night and day, isn't it? On the left, you have the benign adenoma. It's small, neat, well-behaved, with that typical golden yellow color. But on the right, that's the carcinoma. It is a monster. It's huge, ugly, invading everything, with bleeding and dead tissue. You don't need a microscope to know that this one is very bad news.
And this story of order versus chaos continues when you look under the microscope. The adenoma cells are all uniform. They look very much like the normal adrenal cells. But the carcinoma, it's complete anarchy. The cells are a total mess, all different sizes, all different shapes. That is classic anaplasia. You can even see these huge, bizarre, monster-like giant cells.
So to summarize the key differences for you, just think about size, invasion, and prognosis. Carcinomas are big. They love to invade into blood vessels. And because they invade and spread, the prognosis is, unfortunately, very, very poor. These points, Spacho, are very important, very high yield.
And now, for the real drama. We're moving from the outer cortex deep into the center of the gland, to the medulla. And the medulla is home to one of the most spectacular, most dramatic tumors in all of medicine.
So let me ask you a question. What tumor can suddenly, out of nowhere, unleash a life-threatening catecholamine storm in a patient? A storm that sends their blood pressure through the roof and makes their heart feel like it's going to explode?
And the answer, of course, is the mighty pheochromocytoma. This is a tumor of the chromophene cells, the factories that make our catecholamines. Now, it's a rare cause of high blood pressure, yes, but it's a surgically curable cause, and that makes finding it incredibly important.
And here is what one looks like in real life. They can be quite small, but sometimes they can grow into these huge, bloody tumors that have taken over the entire gland.
Now let's zoom in, way in. With an electron microscope, we want to see where all the trouble is coming from. Do you see all those tiny dark dots inside the cell? Those are granules. They're like tiny little bombs, each one packed full of catecholamines, just waiting for the signal to be released into the bloodstream and cause absolute chaos.
Okay, for our last section, let's zoom out and look at the big picture. These tumors don't always happen by chance. Sometimes they are part of a larger genetic story. Now, for all of you preparing for your PG entrance exams, this part is pure gold, so listen very carefully. So, when a tumor is part of a MENS syndrome, multiple endocrine neoplasia, it plays by a different set of rules. These tumors tend to show up in younger patients. They hit multiple endocrine organs, not just one, and they are often more aggressive and more likely to come back after treatment. You must keep these features in mind.
Okay, this table right here, this is your key to success. It is your cheat sheet for the MEN syndromes. MEN1 is very easy. Just remember the 3 Ps: parathyroid, pancreas, pituitary. MEN2A and 2B are both caused by the REAT gene, and both are linked to pheochromocytoma. I am telling you, you must memorize this table. There is no other way.
And this brings us to the most important point. All this genetics, it's not just theory for your exams. It is changing how we practice medicine. We can now test families who are at risk.
For patients with MEN2, we can even do prophylactic surgery to remove the thyroid before cancer develops. So I will leave you with this question to think about. As genetic testing becomes cheaper and more common, what's next? How will it change the way we screen for and maybe even prevent these diseases? Think about it. That's all for today. Thank you.